Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AstraZeneca.
This program is presented by Medscape Education Global.
Hello, I'm Volkmar Müller, gynecologist at the University Medical Center in Hamburg, Germany.
And hi, I'm Erica Mayer from Dana-Farber Cancer Institute in Boston. Welcome to this program titled Hormone Receptor-Positive Metastatic Breast Cancer, Novel Endocrine-Based Strategies and Options After Progression. Today we're going to spend a few minutes together discussing the impact of some of the latest data on the current and future treatment options for our patients with hormone receptor-positive metastatic breast cancer. Of note, we will only be discussing the top-line results of these studies, and we'll try to put them into clinical context from our perspective. Please refer to other programs on the Medscape website for more in-depth summaries of these recent studies. So just to set the stage, I think around the world, endocrine therapy plus a CDK4/6 inhibitor are the frontline standard of care options for patients who present with metastatic hormone receptor-positive HER2-negative breast cancer. So, Volkmar, can we begin by just taking us through the current standards for management for hormone receptor-positive metastatic disease?
Yeah, thanks, Erica. So there's a pretty much established standard, CDK4/6 inhibitors plus endocrine therapy as first line. However, we have the problem and challenge of hormone resistance and/or CDK4/6 inhibitor resistance that occurs in almost all patients. And then low PFS for sequential endocrine monotherapy with established compounds after CDK4/6 inhibition is observed. And another challenge, in my view, is how to manage patients who relapse on endocrine therapy in the adjuvant setting or shortly after the end of endocrine therapy. So there's a need for new drugs with alternative mode of action and new approaches for treatment. As we have now more options available and more upcoming, it is important to understand the biology of the tumor in a patient who progresses after endocrine and CDK4/6 inhibition, and to understand the biomarker status, including mutational status as well as HER2 status concerning HER2 low and ultra-low status. So as we start to think about new therapies, we really need to consider the impact of molecular profiling to match our patients to the best treatment options. So Erica, what are some of your considerations when approaching molecular testing in patients with hormone receptor-positive HER2-negative metastatic disease?
So molecular testing, especially for actionable mutations, such as ESR1 and PIK3CA pathway genes, has become a very critical component in guiding our treatment decisions. So there are a lot of choices when we think about molecular testing. For example, are we doing testing on tumor tissue from a metastatic biopsy, or are we using a liquid sample, meaning we're using ctDNA to do our liquid biopsy? And what are the best times for doing testing? Is it best to do testing at the time of disease progression? So for example, moving from first line to second line or second line to third line? Or should we be doing testing up front at the very beginning? This is really an important consideration when we're using such a powerful tool like molecular testing. But we do know that testing for a broad range of mutations, including PIK3CA, AKT, PTEN, ESR1, this allows the identification of actionable mutations and helps us better understand eligibility for newer targeted therapies. So perhaps, Volkmar, you could mention a few words about one of our newest targeted therapies, inavolisib.
Yeah, thanks. I think that's an important and interesting example of how we improve on a risk group of patients. So inavolisib is a PI3 kinase inhibitor, and INAVO122 was the trial that led to approval of the drug in many countries in this setting. So this drug study, INAVO122, chose patients with a high-risk disease it was PI3 kinase mutation in hormone receptor-positive, HER2-negative metastatic breast cancer and progression during adjuvant therapy or within 12 months of the end of adjuvant endocrine therapy. This trial compared inavolisib combined with palbociclib and fulvestrant with the doublet palbociclib-fulvestrant. And the addition of inavolisib to palbociclib-fulvestrant led to an improvement in PFS from 7.3 months to 17.2 months, and moreover, to an improvement of OS of 7 months a median. So OS for the doublet was 27 months, and for the triplet, 34 months. Finally, also the triplet therapy prolonged the time to first subsequent chemotherapy. So I think this was an important trial, how we could learn to improve endocrine-based therapy in a high-risk group of patients. The first time also, to my knowledge, an OS advantage was shown for PI3 kinase inhibitor. It illustrates the importance of early genomic testing and the high relevance of PI3 kinase mutations, which occur in approximately 40% of the patients with hormone receptor-positive, HER2-negative disease. So for me, this is a good example of treatment escalation in a high-risk cohort. So, but Erika, what are your thoughts about the trial?
First of all, I think this highlights for us the importance of doing tumor genomic profiling at baseline, even thinking about it before we even know the patient has metastatic disease. So when that patient is being scheduled for their confirmatory biopsy, let's send the ctDNA so that we know the PIK3CA status before the patient initiates their first-line therapy. Because we've learned from INAVO120 that this is a very powerful triplet therapy in a high-risk patient population, and we want to know if we can use it. The control arm in INAVO120 with a median PFS of only 7 months, it is really quite different than what we've seen in the traditional first-line CDK4/6 studies. And I think that really supports that this is a high-risk population for whom treatment escalation is really important. Now, the new data that was presented at ASCO this year on overall survival, while quite compelling, it is important to recognize that very few patients who were randomized to the control arm were able to cross over and get a PIK3CA pathway targeting agent. So we're not looking at PIK3CA first versus later, but we're looking at PIK3CA at all versus none. And so that's important when we interpret the data. It's also important to remember that inavolisib has some very specific toxicities associated with it, in particular risks of hyperglycemia, mucositis, diarrhea, rash, and that when we select patients for inavolisib, we need to be very careful thinking about their comorbidities and have to be very mindful about how we support patients, monitor them for the emergence of toxicity, and use both prophylactic and supportive care strategies to help minimize any toxic side effects. So I think we need a lot more work to understand how we can best get this really important drug into patients safely and effectively.
So now we are talking about a different setting. These next topic is patients that were initially endocrine sensitive. So for those patients, the current practice is to exhaust all available endocrine therapy options after first line before moving to other treatment modalities. Also in this setting, classical chemotherapy has often modest efficacy and high toxicity. So new anti-estrogens like elacestrant and emerging ones such as camizestrant might offer new monotherapy options after initial progression and are also of interest for combination therapy. On this table, you just see an illustration how these new drugs, SERDs and PROTACs, we're going to mention them afterwards, are developed. On the left, you see 2 columns with examples of trials examining these compounds as monotherapy. And on the right, you can see 3 trials that examined the new compounds with combination partners. So as we will have more options illustrated here, I think in the future we also might have to change our treatment strategies. And in this context, I think there was an interesting trial, Erika, the SERENA-6 trial. So maybe you could talk us through the SERENA-6 results.
Yeah, so in the oral SERDs are a really exciting space right now and very innovative and honestly well-tolerated drugs. And SERENA-6 was a study presented at ASCO this year that has a really innovative design and very important findings. We know that ESR1 mutations, while rare at time of initial diagnosis of metastatic breast cancer, increase over time as a sign of the development of endocrine resistance. And we know that at time of first progression, about 30 to 40% of cancers will have developed an ESR1 mutation. So these are subclonal mutations. They're not truncal, and they do change over time. So we have to check for them. They do emerge under the selective pressure of being on an aromatase inhibitor, and can be pretty easily detected with any commercial ctDNA assay. So the SERENA-6 trial was based on an initial trial called PADA-1, a randomized phase 2 trial that looked at using serial ctDNA to identify the emergence of an ESR1 mutation prior to clinical progression. After promising data from PADA-1, this led to the development of the phase 3 SERENA-6 study that's using the next generation oral SERD camizestrant as the target agent of choice. So the hypothesis of SERENA-6 is that using a ctDNA guided treatment switch from an aromatase inhibitor to camizestrant with continuation of CDK4/6 inhibitor during first-line therapy at the time of molecular progression, but before clinical or radiographic progression, could improve outcomes in metastatic hormone receptor-positive HER2-negative breast cancer that's developed an ESR1 mutation. So the SERENA-6 trial has a very interesting and novel design that has two steps. Step one is the monitoring step. Eligible patients for step one had already initiated first-line therapy for metastatic disease using an aromatase inhibitor with a CDK4/6 inhibitor and had been stable on their therapy for at least 6 months. That's a little different than PADA-1, where patients entered at initial time of treatment start. Patients then had serial ctDNA testing for ESR1 mutation that was done around the time of tumor restaging, so about every 3 months. What was being looked for was finding an ESR1 mutation, but not seeing clinical progression. So this idea of catching the molecular progression prior to the clinical progression. So this was a global study. There were about 3,300 patients who entered into screening. Of those patients, about 550 of them were found to have an ESR1 mutation, and 315 were then able to move on to the step 2 portion of the study, which was the treatment step. Those patients were then randomized 1-to-1 to either stay on their aromatase inhibitor and CDK4/6 inhibitor with the addition of a placebo, or switch from aromatase inhibitor to the oral SERD camizestrant with their CDK4/6 inhibitor and with a placebo. So it's a placebo-controlled trial. 315 patients moved on. Top-line results from the study, which were presented in a plenary session at ASCO, showed that for the primary endpoint of progression-free survival, the patients who made the switch to camizestrant at that time of molecular progression had a significant and a substantial prolongation in progression-free survival from about 9 months in the control arm with aromatase inhibitor to 16 months with the switch to camizestrant, corresponding to a hazard ratio of 0.44, which was highly statistically significant. Another important finding from SERENA-6 was for quality of life, looking at the time to deterioration in global health status or quality of life. And very interestingly, there was a dramatic difference here. The patients who made the switch to camizestrant had a substantial prolongation in time to deterioration from about 6 months to almost 24 months. So about a year and a half gain before the patients experienced a decline in quality of life. And that's an unusual finding to see in a metastatic ER-positive study. So that was really quite meaningful. So, it's a very interesting concept, this idea of monitoring for the development of the ESR1 mutation before clinical progression. Typically, when we capture clinical progression, mutations have developed, the tumor has grown, and at least grown enough for us to detect on a radiology study. But we know prior to that clinical progression, there can be substantial mutations and development of molecular resistance that occurs beforehand. And if we could identify the earliest moments of that, when we see that ESR1 mutation, we might be able to intervene early and make a change before other resistance mutations develop and the cancer becomes more challenging and difficult to treat. So it's a very interesting and innovative new paradigm that may be a framework for us in the future in terms of treatment or in terms of other drug development strategies. Really, SERENA-6 validates this concept of ctDNA monitoring. It's the first study showing us the clinical value of ctDNA monitoring in a phase 3 setting to look at molecular progression ahead of clinical progression. And it's also showing us that this interval between ESR1 mutation detection and clinical progression might be a therapeutic window for intervention. So a really exciting data that was presented Volkman, I'm curious, what was your take on this? What did you think about this presentation?
But it's a proactive approach, and I think we have a new idea how to prolong first-line treatment and also quality of life in those patients before they become progressive by imaging. So that's the good point. I think there's some, like an ultra, some open questions, so there was no crossover to a new cert like camizestrant or others. And the high number of tests that is required was discussed. This might be a burden for patients and also for payers. And there's a thing about the PFS2. I think for some patients, indeed, it was a PFS3 because they had received 2 lines of therapy before. But still, I think it's an interesting trial, and I think it's going to change the way we treat patients in this setting. So that's my thought about that.
Yeah, I absolutely agree. And, more to come as we as the breast cancer community continue to digest these results and think about how this might impact our practice. Another highlight at ASCO this year was seeing some data for the investigational PROTAC vepdegestrant. Could you tell us a little bit more about the data from vepdegestrant from the
Yeah.
VERITAC study?
So VERITAC-2 was a trial with vepdegestrant, and that's a new class of drugs, PROTACs. So I had to learn that. Proteolysis targeting chimera. So the idea is to target the estrogen receptor and also give some target for degradation by the ubiquitin proteasome pathway. So this is a universal general mechanism that could be used also for other proteins. Indeed, VERITAC-2 is the first phase 3 trial of any PROTAC in this clinical setting, and it compared vepdegestrant, the PROTAC, versus fulvestrant following disease progression. So the primary endpoint, median PFS in ESA mutated patients, was reached. So PFS was only 2.1 months with fulvestrant, something similar we had seen in other trials also, and 5 months with vepdegestrant. Hazard ratio 0.57. So this is, again, I think, one way how we could modify treatment. So Erica, what are your thoughts about this trial?
Yeah, I was really excited to see this data on vepdegestrant because it has such a novel mechanism of action and in some ways complementary yet different than what we've seen with the oral SERDs. So I found this data very compelling. It again shows us that endocrine monotherapy with an agent such as fulvestrant does not perform well in this setting, and so we need better agents, particularly in the setting of ESR1 mutations. I think that what I'm most interested in is the idea of combining vepdegestrant with other targeted therapies. We're beginning to see that data coming out with the oral SERDs. SERENA-6 is an example of that. And I'm looking forward to seeing more data with vepdegestrant in combinations. I think that's when we're going to really unlock the best abilities of this drug.
So finally, we are summing up. So as you have seen, we have new strategies being explored for different patient populations to optimize time on first-line therapy and subsequent lines. So we saw new options for endocrine backbone and endocrine-sensitive patients. We saw watch and switch therapy, monitoring resistance mechanisms using ctDNA in endocrine-sensitive patients receiving CDK4/6 inhibitors plus aromatase inhibitors. And we saw new options for endocrine refractory patients, new SERDs compared to fulvestrant, better than fulvestrant. ADCs are also altering the treatment landscape, providing options for targeting HER2-low, ultra-low populations. And all of these new strategies provide good new options, and there's still much more to come. So I think good times for treatment of breast cancer patients with metastatic disease.
Yeah, well said. And I totally agree. These are good times for us and a lot more to come. So thank you so much for joining us in this discussion on the impact of new data on novel endocrine-based strategies for the care of patients with hormone receptor-positive advanced breast cancer. Thanks again for joining us.
This program was presented by Medscape Education Global.